Once again, I'm delighted to welcome all of you to Town Hall number 10 for the VSSNA this 2020-2021 school year. As you know, we have our favorite special guest with us. I just want to cover a couple of housekeeping things before we get started. Please know that we are capturing the questions and getting the answers, but the last several town halls, you have not seen those yet. It's all related to the amount of time that we're spending doing what we get paid to do, but we're going to continue to capture those questions and get those answers because it is very important for all of us. Continue, please, to send your questions to COVID-19 dash, whoops, whatever it is, COVID-19 at vssna.org. Right up front, we will not get through all the questions today, but Dr. Holmes has agreed to come back same time, same place next week. And again, recognizing the urgency of your questions and concerns, we appreciate your support of each other and of us as the VSSNA Executive Board. We're as busy as you are. We are so excited to have that brand new guidance out. And Breena, thank you so much for agreeing to walk us through the changes that that brings to us. So I'm going to turn it over to you, Breena. Thank you again.
Thank you, Soph, and thank you all. I have a few sort of opening remarks as well, and then we're really going to dive into your questions, which I get so much support every time from Clayton and his technology skills. I'm grateful. And so for the next slide, I just really continue to feel such gratitude for you all. I know how hard this is. And I know that your days are really long and they're really uncertain. I thought last Friday was really a wonderful moment for your field of school nursing when both Secretary French and then Dr. Levine really unscripted, just amplified Secretary French's gratitude for school nursing. I could have written those remarks because I feel that way about you, but he did that on his own because he's a really tuned in leader and he knows what you're all doing every day. So that was last Friday. It seems like a lifetime ago, but here we are on the 29th of October. Next slide. I don't have to tell my science friends, we're not learning as much as we learned in the beginning, but we are always humble and always admitting when we've said something that was not accurate. So here we are again today. Next slide. So before I get into the summary of changes in the guidance, I wanted to just note my experience as a person who is familiar with all the cases in schools. And I am familiar with all of them because we have a huddle every day, and I'm as you know, part of the school and childcare branch. So the ice sports situation in central Vermont is now, it's going to crest up. It's going to be over 80 cases associated either primary, tertiary, or secondary or tertiary from that ice sports situation. And as you may know from the press conference and from the way that Dr. Levine is speaking very openly about this, that initial outbreak led to the St. Michael's situation. And it's associated with at least 6, if not 7 or 8. We're investigating 2 more situations today. It could be up to 8 public school environments, all back associated to the ice sports initial outbreak. So what this really drives home for me, and I need to say like 100 times, and I want you to say to all of your school staff, this is about what's happened in Vermont in the last 2 weeks is about adult behavior, relaxing of prevention strategies, and fatigue. It is not about kids transmitting. It is not about the science changing, that maybe we weren't right about our guidance or there was something. almost no transmission in schools. I can't say there's no transmission. There might have been one adult who gave it to another adult. But in terms of everything we've been saying to you, well, really to your colleagues in childcare since March, is continuing to be supported by the data that kids don't transmit this the way that adults do, and that adults bring this virus into the building. The other thing that's so shocking to me, but I have to just share with you, is people are working symptomatic. People are moving about in society symptomatic, and they're working in schools symptomatic. And we could probably spend the whole hour trying to analyze that, but I wonder if you're in the middle of that. And we've got to double down on symptom screen. Okay, so here's what's going on in the guidance. We needed to get a little bit tighter on the travel. So as you know, the daily screen in the early days of our guidance did not include travel. We thought it would be complicated, and folks doing the screen would have to pull out the map. And we were really hoping that that was more something that could be handled at the individual level, but it's turning out that people are traveling. So there's an added requirement to screen for have you traveled. And then we continue to know from all of your great feedback that this return to school illness algorithm just needs a lot of conversation. So we just put it in more clearly that we want that really to be the tool used by our clinical decision makers, school nurses, medical homes. Next slide. So we spent a long time in the task force. In this last iteration, there were 6 meetings with all that original great thinkers, and the infectious disease specialist said, we have to keep updating how you clean, how you isolate, and perhaps, and they back this up with good science, we set forth early back in August with more stringent requirements. We now know that you don't have to leave isolation rooms for hours. That doesn't really change the virus. What you need to do is treat it like a health setting, because it is. And in the health settings, they are seeing patients, cleaning the room, seeing another patient. We wanted to make more clarifications on the factors that the health department will use in making recommendations when there's a case in a school. This is really going well. I'm sure you've heard from your superintendent, and those of you that have experienced cases could really support each other, your nurse colleagues who haven't. It is a very thoughtful and intensive process when the health department pulls together with a school, and it's slow and steady, and it does involve almost always a public health recommendation about a certain pod needing to quarantine, and then a school decision that they might have to go remote learning for more than that pod or for more days than we would recommend. And that's based on staffing and some of the other factors in COVID that are not just about containment of the virus. So I feel like those dialogues have been very rich and very meaningful to be able to say to a school administrator, you obviously have autonomy to make decisions about remote learning, but it is not a public health recommendation. And that's really important. We also have great transportation leadership on our task force who put forth the best national thinking on how to set up a bus with windows open, but also heat to minimize the spread of the virus at the same time acknowledging it's getting cold. Next slide. Okay, so we learned early, the first few cases in schools we learned a lot from, and we are just getting more specific that we obviously, schools are amazing and we always know where kids are, but just a little bit tighter understanding of especially little kids that move about and don't have good recall about their whereabouts to have seating charts. We also want to continue to talk about this very rare occurrence when a child would have a mask exemption medically. I'm sure you're having a lot of questions about that, but please use your medical home and develop a team around that decision with special education. We've added some more about cleaning. There's definitely a sense or science from Drs. Raska and Lee that this is not a virus that's really spread on surfaces the way we initially thought. It's an aerosolized respiratory virus. And then the plexiglass piece. So your questions are going to be a lot about this. We included the guidance from the National Occupational Health experts who talk about how you can use plexiglass and how to clean it and how it has to be set up. And that's all explained well. But perhaps on the next slide, Clayton. I guess I could answer this now. It's not specifically in this bullet, but the biggest change in the guidance is that Dr. Levine and Secretary French and the governor's leadership team spent several days thinking about, could you use plexiglass to shorten the distance in the older kids to less than 6 feet? And they ultimately decided as our state leaders that 6 feet needs to be the distance, and that plexiglass can be used as an additional measure for various settings, or if you happen to have it in your school and it's times when people have their masks off or other times, it's all fine. It's just not in place of the distancing recommendations. We did recognize from the surface research about the virus not living on surfaces that shared materials are okay, and that we did start out a little stringent on that and have softened and relaxed. We ultimately still decided lockers had too much risk. And then maybe we should have led with this, and we knew this actually ahead of the guidance actually finally getting finalized, because the Agency of Education allowed us to talk about this a few weeks ago. The science on the age when it becomes, when students start transmitting more like adults is really more about puberty and biology. And so we decided that we couldn't do an age cutoff, but we really, there wasn't much difference in research between a 5th grader and a 6th grader, and that in order to support the configuration of some of our schools, it was safe to recommend the shorter 3-foot distance in pre-K through 6. And then, as I said in the plexiglass sentences, we spent a long time as a task force talking about physical distancing, and then ultimately our commissioner and the Secretary of Education made the decision that they were going to be hardline on 6 feet. Next slide. Okay, one of the things I'm most proud of, and it's ongoing, is our conversations about music education. I feel that we are seeking equity as a task force because there's tons of attention on our sports teams and how they can be safely engaging young people. Music is hard, especially singing and woodwind, and obviously with the respiratory virus, there's a lot of concern about singing indoors, playing woodwinds indoors. So we were able to put some recommendations in based on science that you can sing or play woodwind alone in a room and then have a break in that room and someone else could come in. The music education people have asked to speak to us again. And next week, Drs. Raska and Lee and Elisa Stolberg and Breena and the Secretary French are meeting with them to continue this important dialogue about how can we safely engage, allow for the engagement of young people in the performing arts. Just a lot about driver's ed, wondering about, because there are obviously rules. A driver's ed instructor needs to have 2 students in a car because one is, adult and student interaction that they like having 2. And there's a way to do that safely, and we've identified that in the guidance. And then ongoing conversations about the public use of those great school buildings, including voting. Next slide. Yeah, and then we continue to discourage the, well, I guess discourage isn't quite the right word, but it's not a great idea to be doing indoor field trips, but we certainly allowed in the guidance for some very specific ways to do that, which would be if you could keep a pod together to go visit somewhere that was really that there were no other student groups there. I'm sure you've read through the clarification on isolation space. A lot of you, most of these questions that we addressed in this revision are because of your great thinking. We continue to have environmental health teams at the health department advising the HVAC situation. And then cafeterias, you know, we said maybe in the second draft or the second guidance release that perhaps you should wait in between cafeteria use of groups, and it was somewhat arbitrary to do an hour, and then we looked at the research and that wasn't necessary. So the guidance now is you can have groups come and go, but they just have to enter and depart in different pathways. Next slide, please. Okay. The other thing we unroofed really early on in cases in school was contact tracers. Ask every human who's been identified on a line list from a school or a workplace or anywhere, have you been within 6 feet of Johnny or Sarah? And that very first meeting with an elementary school leadership team looked at me on the Zoom like, wait, what? You told me since August we could do 3 feet, and now these gals are asking about 6 feet. So we put this much more clarity in this guidance that contact tracers use 6 feet out of the abundance of caution, and it's a way to just get a really wide swath of understanding where a student or a teacher may have been, but it is not changing the safety that we outline in 3-foot spacing of pre-K through grade 6. Okay, next slide. I think we're on to your questions. Added from the chat box. That's a great title. Okay, let's just get right to it. What I love about your questions is the level of specificity increases every week, which is exactly where we need to be as a team. Is there a written source that provides guidance on allowing non-symptomatic family members to attend school when another family member is home? So it's not written with a school lens. It's written as a quarantine rule. So if anyone's quarantining, and that includes someone that's awaiting a test result, the household does not quarantine. And it's under the frequently asked questions. And I don't know how much success you have with the chat bot, but I found it today because I was on a doctor call and they were asking this exact question. So Sharon Lee and Nate, when they're on this call with me, they're often very successful at putting in the chat box the exact language, but it's an FAQ that says, do I have to quarantine if I'm living with someone who's quarantining, which is essentially what this question asks. Okay, next slide. Use of rapid testing in schools. With the increased incidence of positive cases and increased illness in our schools, why are we not using the rapid tests instead of saving them for January? Okay, so first thing, no, we're not saving them. And I'm curious if you've heard that. There are meetings every week about how to use the rapid tests that have come from the federal government. They are antigen tests. And as my scientific friends, I want you to know antigen tests have false positive rates, especially when used in asymptomatic testing, which is one way to test a bunch of people in a school or a long-term care facility or another workplace. If we're going to go forth and test asymptomatic people, you as COVID coordinators and school nurses are going to find yourselves in a very odd couple of days when a positive antigen comes back on a staff and you don't have confirmatory PCR. There's going to be fear and confusion. And I don't know if we're heading this direction, but I do need you to know that the rapid tests have false positivity rates. If you use them with sick people, they work better, but that wouldn't be in a school setting. I would like you to know, as your community medical folks, who's doing the test, how can you get rapid tests? So what I really want to air out with you all as people on the ground, living day to day, is if you need someone to get a test in your community, how easy is that? And I talk to the pediatricians every Monday, Wednesday, Friday, and we talk about if your school nurse calls and says, this kid has these symptoms, I want especially November, December, January, February, I want those kids to get a test. And sometimes that's in the office, sometimes that's at the hospital. Sometimes there are communities that have pharmacists that are testing symptomatic people. Sometimes there are urgent cares, but you have to know your own resource, and your school liaisons can help you with this. So there's so much in this question. I do want more testing. I want symptomatic people to know their COVID status, but I'm not clear I know for sure that the rapid tests are problematic. That doesn't mean they don't have a use, but I just don't want to overstate their what they could do for us in a school setting. And so if this person that wrote this question wants to email me directly, I don't know where you heard the January piece. This is really a conversation about the next few weeks. It's going very quickly of how to get the rapid test deployed to a community, but I'm not clear they're the best uses in schools. So let's stay in touch. Next slide. The CDC says masks shouldn't be worn when wet. What about kids who are outside in the rain or athletes during practice in the pouring rain? We get this question a lot. I always want people to have two masks, one wet that you can trade out. If you go out in the rain, it's wet, and then you come in and you put on a dry one. So if you're having challenges with access to masks or kids don't have piles of them, I wish everyone had 2 or 3. And athletes, yeah, they're doing the best they can. I mean, what's implicit in this question is they're outside, and I love when people are outside because their risk is so much lower of either spreading or contracting the virus. So the wetness of the mask is a lesser concern with the outside. But let us know, or let your district office know, if your supply of masks is inadequate for changing out wet ones. Next slide. Cleaning, disinfecting, sanitizing. Does the portion of the guidance that states cleaning and disinfection products should not be used by children or near children pertain to wipes? It pertains to everything, because the environmental health folks were very clear that using children to wash their own areas had some inherent risk to their, if they were to overuse a product or have an exposure that was, longer or beyond what an adult would regulate, they didn't like that idea. That being said, wipes, I'm not worried about you handing wipes to kids and telling them to wipe their desk. What the environmental health folks were more concerned about is a spray bottle with a concentrated cleaning solvent and a child sort of on his own overspraying. Is it safe to assume soap and water are okay for children? Could they use a green cleaner? So yes to soap and water always. I think green cleaner, maybe, but what I want to avoid is a long analysis of product ingredients and having to parse that at the classroom level. So I think it's safer to say students use soap and water or wipes, and the rest of the cleaning solvents are adults. Next slide. If teachers have been cleaning surfaces a couple times a day, does the custodial staff need to do the cleaning prior to disinfecting at the end of the day? We get asked this a lot. So we did, in the guidance, we are talking about a lot less cleaning. And you're right, a couple times a day. It's really going to be up to your school staff how you want to manage who cleans when. But if you read it and see, we're really talking about maybe use the beginning and the end of the day. And I think you could talk as a team about how you interpret what's in the guidance, because it certainly doesn't need to be the level of cleaning you did prior to this change. We're struggling with having enough coverage for the detail that this guidance suggests around cleaning and want to be sure. Don't know exactly what that means, but I hope you see that we're actually really recommending less cleaning. So hopefully you'll have more coverage. But maybe I'm not understanding. Next slide. Do PE teachers need to allow for an hour between indoor class? The note on page 27 appears to override to the time requirement in the FAQ. Yes. So I should have said this at the beginning. We are working very hard to align all the FAQs that have been out since August back to all the changes we made in this guidance. And I will also acknowledge, thanks to Soph and others, we were so focused on getting the distancing pieces right at the onset of the document that we found places that it was discordant later in the document, again, 41 pages. So I really appreciate when you're noticing discrepancies. I also really appreciate when your superintendent leadership does, and they sent us extensive emails about where it's not clear. So this is an example of where the FAQ will be fixed to align with page 27. So the answer is you don't need the hour in between. The shared spaces now, you go in one door and another group go out the other. Next slide. Is it okay to not wear a mask if you're alone? Okay, we said very clearly in the guidance you wear masks when you're in schools, and we did that on purpose because we want there to be a very clear expectation about masks in schools. When you call me and say over the phone, but can I take my mask off and sit in my classroom alone if I know no one's coming in? I say yes, because I am able to bring common sense into the conversation about this virus. I don't know if everyone is, and I don't like to put in writing that you can take your mask off if you're alone in a room, because we're hearing interesting stories of, you know, people coming in and coming upon teachers without masks, and then they don't put it back on. Or there's a few people that come in and congregate, and then it's realized later that the mask had been off because you had started the room alone. Do you see? It's so much of this is your own, and I guess not so much you as health people, but the other adults around you. They need to have their masks on when they're in school, right? So, but does that mean you can't go into your, you know, a one stall restroom or go down to your car and take a break? That's the piece I want to, you know, not overstate, but definitely encourage. Does this also apply to food service and cafeteria? If they're preparing food alone, I don't think so on that one. Again, I don't know enough about food prep alone to think, isn't there a chance adults will walk in? I think so. We just don't want to look back and say we relaxed alone without recognizing we were only going to be alone briefly. Next slide. The adult algorithm. I'd say it's 96% of the way there. It's hard though. The adult infectious disease doctors, almost all the symptomatology is leading toward testing. They didn't feel comfortable with that middle group of symptoms the way we did in the pediatric algorithm, where we were able to use clinical decision-making, alternative diagnoses to send kids back to school. The adult algorithm is much more about who can wait out a couple of days and be well and who gets a test. So we put it out into the field for a lot of adult primary care doctors to look at, and they're bumping along and giving good feedback, and our epidemiology team is too. And so it's hard for me to predict. I guess I'll promise it next week, because at some point we just have to call it, right? We can't have any more feedback because it's not going to be as useful to you all as pediatrics. I'm just going to acknowledge that it's going to require more testing, but maybe that's where we find ourselves now, and you're going to be all right with it. So I'm actually fine to share it if people want to take a look at it. Clayton, just remind me at the end and I'll send it. I can't take everyone's feedback, but maybe if, I give it to Soph and a small group, if you want to take a look, I'm very willing. It's not a private document. Next slide. Should school districts be accepting quick antigen tests for adults? No. I mean, for the reasons previously stated, they can certainly begin the journey of worrying that person has COVID, but until there's confirmatory PCR, that's not COVID. Do you see how complicated this will be in a school setting though? If antigen test comes back on a teacher, our contact tracing team takes that very seriously, comes back positive, and begins the process of recommending quarantine for close contacts, which will occur a couple of days before. So say then you get a confirmatory PCR the next day, and then it's 2 days for results. Now you're 4 days out, and then it comes back negative. You've had a whole group of kids, a whole group of adults quarantining for not COVID. So, now that being said, please don't misunderstand. Antigen tests are more accurate if you're sick. So if some clinic is using them and there's a very, very, a symptomatic adult it's going to likely be that that's an accurate test. Does this make sense since adults are known to spread COVID more than children, and children are required to have PCR according to the algorithm? Yeah. I mean, this is, it's my opinion, but it's also the infectious disease doctor's opinion. So I don't feel like I'm out on some limb here, but you know, you may find a lot of folks around you starting to get antigen test results. But I will tell you that almost every day, there's a PCR that comes back negative after a positive antigen. Next slide. Can you talk about the test being done at the airport? I meant to look this up. I know there's tests at the airport, but maybe one of my colleagues on the call could determine if those are antigen or PCR. There are rapid PCR tests available. And so Kara's noting it's an antigen test. So there it is. You've heard now from a few different questions and slides what the pitfall is here. But there is utility to antigen testing in this pandemic, but it's, in my opinion, it's for sick people. It's when you're in the emergency department and you're trying to figure out the disposition of a patient. Should this person go to, is this person going to test positive for COVID and needs isolation right now, and it comes back positive, you isolate them. And then 2 days later, finding out it's negative is not, no harm, no foul. But in public education, it's you know, fraught, because so many people are going to have to step out of education while we're waiting for confirmatory PCR. Are we accepting these as valid if people take them and want to return to school after being ill? That's a twist on this. Let me think about this. Person. So I'm going to hedge on this and say that if a person's illness is resolving and they're negative antigen, yeah, let's see what the adult algorithm, because you're talking about adults, I think here. This would not work in the pediatric algorithm. The trick would be where were they in their illness, because a negative test is only good that day. You know, if a person, yeah, I need to know more about that person. It's very case by case. Next slide. The new guidance is effective the 16th. Yes, yes. Well, so as a leader, you could start making the changes right now, but you have other bosses. And the superintendents were very clear with the Secretary of Education that they need an effective date because they want an on-ramp for the changes. I imagine they mean they needed the on-ramp for the distancing changes. So I don't know if they're willing to allow your school to function in the guidance with all these other shifts. If I was in charge of the universe, the answer is yes. But I've learned that educational leadership is not always the same, and that some people want more order to changes. They don't want everything to be real time, and I have to allow that. Yep. Next slide. For schools who run instructional ski programs, can large groups of students across grades ride the same bus to the ski mountain? So this is the pod question that we get asked all the time. And there's got to be a lot of careful thinking about how this is going to work, but it is allowable. So if you think about a group of students who currently are in a public high school, they have their kids in English, and then they have a group of kids that are in science with a group of kids in math. So if then there's another group that get on a bus together and go ski, same principle in play here. Pod mixing is allowable. We need to know who's on that bus, and we need to know everything about them. They have to be well. We have to know where they're sitting, etc. Can volunteers assist students outside at the mountain? Now there's a question. I would rather this be thought through at the school level, because if you're outside and you're 6 feet apart and you're, it's okay, but the word volunteer is throwing me off, because we're very careful in the guidance to say that we're not really allowing parents or volunteers in our public education during COVID to minimize the number of adults in a building. but this is outside and it's sports. So I'm going to have to table that one. It's, you know, my personality, as you know, this seems very reasonable to me, but what do we know about that person? Are they having a symptom screen? Do they work for the mountain? Are they part of the school district? Are they coaches? You know, there must be a lot of rules about this anyway, just from child protection. So I'm going to table that and wonder if someone knows better than I do. Next slide. Oh, I love clinical ones. In cases where a student has a single symptom, like example, vomiting or diarrhea, is the guidance that that single symptom must not last longer than 24 hours and to be able to return 24 hours after resolution? Or is that parameter for lasting not more than 24 hours only related to fever? If they have diarrhea for 2 days but no other symptom, can they return 24 hours after the last episode? Yes. So this is a perfect example of how I trust you all, and I want you to use your nursing critical thinking and clinical decision making. So single symptom can last for several days, be resolving or improving, and you can return to school, which is exactly what you're describing here. So I want us all, and this happens all the time with contact tracing as well. We have to slow down sometimes and just ask ourselves what we're asking ourselves. And you had such good decision making pre-COVID. So all we're saying with a single symptom is it's not COVID. So once you're in that belt or that lane, how would you advise a child to return to school in general? And you'd want that diarrhea resolved, but you wouldn't really care how long it had been. How many days symptomatic. Okay, next slide. Could you provide more clarification on when the use of an isolation room would be appropriate? Any time a child develops symptoms of COVID, anything on that long list of symptoms, or an adult, although an adult doesn't have to be isolated because they can just get in their car. So anytime you have an ill child, you have to put them in isolation while you're waiting for them to go home. Next slide. Oh, I love that you're thinking, should we allow fully remote students to come in the school for vision screening? I'm going to give this one to Sharon Lee. I think it depends, you know, tell me more about a student that would choose to be fully remote, if that's a parental decision for fear or, you know, a personal decision about a family's health. That student should be encouraged to be screened at their medical home. Are you unmuting? Okay, Sharon Lee's typing in.
Yeah.
Do you want to answer that one? That's a good one.
Yeah, I would think the same screenings would apply. The travel, the temperature, all of the other health things. And then if your screening procedure is set up to allow distancing and the guidance in the FAQ online about vision and hearing screening, it would be great. Are you muted? Okay.
He's all.
Am I back?
Oh, there. Yep, you're back
Oh,
now.
good.
Thank you. You're good.
It just said the host muted me. That would be such an effective tool, muting Breena. I was just starting to say how your ability to think about all that you have to manage in a pandemic and still be thinking about you know, health supervision and important screenings for kids, really, that just warms my heart. If plexiglass can't be used to help with 3 feet, what's the purpose? So the purpose is some folks just feel better when there's extra protection. Some folks are using it in when kids have their masks off to eat as just an extra layer of protection. Some folks are using it if they feel that there's going to be an extended time when people are going to be facing each other and they just aren't sure if kids are going to maintain the 3 feet. Some people are using it in special education when there's a brief moment when a student or a speech and language pathologist wants needs to be unmasked. It's that type of thing. It's just not meant to bring people closer than the current distance guidance. Next slide. If school-sponsored indoor sports are allowed after school, why aren't physical education classes allowed during school? So I've been getting this question a fair amount. I didn't know physical education classes aren't allowed. I thought they were allowed. So either this is I'm off base, or this is a misinterpretation of the guidance. We never said no PE. In fact, PE is, I know I'm a health educator and I know a ton about physical education. It's not sports. It's a true educational class and it's occurring. So again, without knowing who asked these, please follow up, because physical education is, oh, Becca's helping me. So Becca's saying that physical exertion is not allowed. That is true. So stay tuned, my science friends, because the winter sports guidance is coming. So like today, tomorrow, and I think we're going to have a very interesting philosophical conversation about it as a team of people. And I'll leave it there because I don't know the specifics. I'm not being obtuse. I just think you're right. I mean, this physical exertion indoors is going to have to, PE is going to have to, they're going to have to be allowed to do it if we're going to let kids play sports indoors this winter. I mean, I'll work with Soph on that. That's going to be important. Next slide. Where's the line drawn between educating families of the travel quarantining guidance and policing or enforcing it, especially on that darn New Hampshire-Vermont border? I would like to answer this question as a strength-based person, which is, and we talked about this on the Monday, Wednesday, Friday call with the docs yesterday, and a couple of the pediatricians gave lovely language that you just, when a family, you share the information that it's not safe to go somewhere, and then a family says they did it anyway, or as happens with a lot of school personnel, the child tells you they've traveled, and you just continue to say, but gosh, we're all working so hard to keep each other safe, and I continue to, I want to make sure you understand that travel is very dangerous for the health of our incredible state. And just stay strength-based and continue. I don't believe in policing or enforcing things like this because this is health behavior. This is the same thing as, hearing that people attend a wedding or go to this ice sport event or set of events, and to start, we have a very important strength-based role as healthcare professionals. We don't believe in shaming. We don't believe in stigma, but we continue to bring forth the best information we have so that people make the choice that's healthy for our whole state. And it's bringing out for me a lot of my personal philosophy about just community. And, there are always folks in communities that, may or may not abide by different health decisions, whether it be immunization or other things that keep society safe, but we all pull together and try. I promise you I'm not a Pollyanna. I just know what this feels like from a health perspective, and it's just education and continuing to ask people what do they need to understand or know more about to really enforce that we are in big trouble with the states around us and their rates of COVID. And so I'll stop there, but I'm sure you can learn from each other on this too, because you're all amazing. Next slide. Okay, I think I talked about this a little bit, but I'll try better. Can you clarify the notation? There's no one else in the room with the musician. So that really truly means alone. Are the teachers allowed to provide lessons? No, this is about students practicing alone, or adults if they choose to. How can we leave students unattended in a room? Well, that I don't know. That's an education question. I assume certain age of kids, that's permissible. And can an adult teacher be Oops, the chat just blocked my, how do you make the chat go away? Oh, there we go. Can an adult teacher be in the same room playing a wood instrument? No, no, you can't have two people in the room at all. So if it doesn't work for certain ages, this is just a teeny little baby step, but it's not going to get you where you need to be, which is heartbreaking. I mean, you know how Soph keeps talking about going outside with students? I just think put your coat on and go outside and teach a student. That's what I would do. Next slide. Neoprene masks. That's a first for me. I don't know the answer to that. I will look into that unless someone else knows. You know, you guys know as much as I do about certain things. So Sharon Lee, maybe put that on the list. I think so. Neoprene's pretty thick. You know, I'm being very common sense oriented with masks because I'm not going to start measuring people's thickness, and I'm definitely not going to ask, is that polyester, cotton? I'm looking for 2-ply, you know, as you know from our previous conversation about gaiters, and neoprene is pretty thick. I'm good with that.
Dr. Holmes, we did discuss about the neoprene masks was the possibility if it's like for skiing, it might have holes. So it's easier to breathe, but it keeps you warmer. So that might become more of the problem is that how the mask is actually made. So
that's a great point.
We didn't have a chance to really look into it more than that, but that would be part of the question, I think.
Okay, good point. Next slide. Okay, here we go with our classroom setup desk direction. We get these questions a lot. So step 2 guidance states turn your desk to face in the same direction rather than facing each other. And have students sit on only one side of the table spaced apart. So I really need to clarify here that I don't think you're talking about step 2 here. I think you're talking about previous guidance. Steps 2 and 3 really are much more basic than this. They just talk about if your epidemiology allows, you can be a little bit more relaxed about the use of your cafeteria and your gym, and you can have more people in a room and more face-to-face instruction. It's not really about the desk. So if I'm wrong about that, someone needs to correct me. But that being said, we want people to use common sense with the way the desks are set up. And we know that the easiest way to keep students spaced is at desks facing forward. But they turn and they talk and they work side by side, and we're aware of that. And we also know that some schools do not have desks and they are using tables. And we think as long as they're 3 feet apart, they can face each other, they can be side by side, but there needs to be no time without a mask. So I'm just a little thrown off by the step 2, 3 thing here. Maybe I didn't read enough about that, and I'll stand corrected, but it really is more about classroom setup in any stage. How do you get that distance to abide by the 3 feet? And some classrooms can do it by tables and some can't. Next slide. Can you speak to how the decision to not quarantine library books came? Yeah, I sure can. And I can send you, because it's actually quite comprehensive, the analysis from the infectious disease doctors of the data about transmission on books. And they were just recently asked by librarians in Vermont about it. So I have the actual citations for you to read. I'm making myself a note, because if I try to talk about it, I'll misspeak. So promise you that was a scientific decision. Next slide. Pertaining to asthma and allergy, at what point do you say you must stay or go home? Looking at the algorithm, if an asthma student comes down to the nurse with a complaint of cough, diarrhea, do we follow the algorithm for only the diarrhea, the cough, or the diarrhea? This is a good question. Again, I really want you to think about your nursing critical thinking. So if the child has a chronic cough that has been deemed asthma, that doesn't quite line up with me clinically. It means it's not well controlled. But if there's a medical home involved and they're working on gaining control of the cough through the use of certain types of medications, then I would see cough as chronic and ongoing and treating in a treatment space, and the diarrhea was new and a single symptom. But if the child is not known to cough, has well-controlled asthma, and has a new cough plus the diarrhea, that child should be excluded. But either child should be excluded because they're new symptoms. The diarrhea, the single symptom still sends a kid home. It's just when they come back can be simpler. And how am I going to really tell if congestion is allergies? I really want you to use your school liaisons and talk to your medical people and figure out how you want to know and learn the student's baseline health in your school. And I hesitate to say like medical clearance and bureaucracy. I just really want communication. And we've just had such a good fall with our school liaisons working this out with our teams so that it's not something I can standardize at the state level. It's just really how do you know if a child has a food allergy would be my question. And then if it happens to be more of a seasonal allergy, that should be the same communication from a medical home. Next slide. What's a recommendation on students bringing food to share? Would prepackaged food be permissible? Would home-baked goods be permissible? I think this is addressed in the guidance, but I'm not positive because we definitely are, we've been asked this. I don't know where we landed though, so maybe that's a Sharon Lee one as well. We had Rosie Kruger from the Agency of Education, who's just terrific. She was a big part of this last revision. So I'm going to have to table that with lack of detail right now, but we'll get back to you. Prepackaged food is permissible, yes. That I know for sure. The home bake, yeah, go ahead.
The home baked goods falls into the same allergen safety protocols.
Yeah, you mean you can bring them if they're, yeah.
Yeah, allergen safe, but you can't share them.
Okay, good.
See, yeah, that's
Thank you.
the adult is passing them out, and so that has to fit into the allergy protocol for the school.
Okay.
That's the way.
Next slide.
But great.
Our school district is considered remote only learning for Thanksgiving. Is 1 week enough? Is there going to be a scheduled remote learning? Should be 2. Okay, here's this topic. So first of all, the Agency of Education, the governor, Dr. Levine, there's a lot of statewide energy to determine if we should have a break, which would really just be a week after. And the reason is, if the last exposure, if a person the Friday before Thanksgiving could be like day 0, then the return, depending on how you count, is, day 10. If you were to take a whole week, well, no, if you were to take the 2 weeks, because Thanksgiving break is a week, and then there's another week remote. So there's a lot of iteration going on at the state level with no decision. But we've also heard that a lot of school districts are thinking about this from their own perspective. And school districts have autonomy to make decisions about their calendar like this. So this is going to be fascinating for all of us in the next week or two. I don't know exactly how I feel about this medically or scientifically, but I get it. I'm not completely opposed to it. How about that for a hedge? Because I feel like I hear from a lot of you that people are going to travel despite all of our advice. And we're pushing out a big public health campaign about please don't travel. And our beloved Dr. Levine talks about it every press conference. I don't know if people are really going to do it anyway. I hope not. And I don't just mean families. I mean teachers as well. And I'm curious, it's not just travel, it's gathering. So if you don't travel, but you still put 20 people in a crowded living room, it's the same risk. Or maybe not the same risk, but it's still a risk in communities. So let's see. I mean, I think you'll probably be doing your own staff conversation. I'm sure your leadership is asking about this, what your thoughts are. And, it has some merit, but it also would have to be done. And, how would we know when everybody came back that they were COVID-free. I think I just need more detail to understand. And I'm getting the hook from Soph. So I think I should stop there to give us 2 minutes to wrap up, acknowledging we didn't finish. We didn't even, and the chat was so active. I'm so sorry I didn't get to it.
Breena, again, we want to thank you so very much and remind our attendees that you have agreed to come back next week. I'm kind of thinking sometimes maybe we just need to move in together. Not a group
After
size that's too
quarantining,
big.
you're welcome at my house, but you have to quarantine.
Just because there are so many questions and yeah.
Well, let's capture them. I just want you to know that this, we are heading into something here. Things are shifting. And I'm always going to be so grateful for that we started, that we've had really positive experiences for young people, and that we're continuing to. I'm really grateful we've got so much face-to-face learning going on. So, but I also know that, I'm not Pollyanna when it comes to the virus, and I want to stay in very close touch with you because we've had a few good days. I will tell you that. Last week and the weekend was like, because of the ice sports and this huge outbreak, we had a lot going on, but we've had a few good days. So maybe that was enough to get Vermont back on track with prevention and not relaxing with our behavior. So we'll keep trucking. I'll see you next week.
Thank you so much. We appreciate that. Thank you all for joining us. This recording will be posted as soon as Clayton gets it up there. And again, keep sending your questions to us, please. And I guess that's it. Thank you all so much. We'll be in touch.